Welcome to MedEvidence, where we help you navigate the truth behind medical research with unbiased, evidence-proven facts. Hosted by cardiologist and top medical researcher, Dr. Michael Koren.
Hello, my name is Dr. Michael Koren, and I'll be leading a unique program of our MedEvidence podcast today, in that instead of speaking with another medical professional, I'll be speaking with one of our patients. And this was an interesting opportunity for me because one of our patients, who has a little bit of background in media, was keen on talking about what his experience was like when he signed up for a clinical trial, and he's actively participating in a clinical trial. And I'm going to depart from our usual protocol by not using your name, because when I talk to another medical professional, it makes sense to use their name. But because you're a patient, I'm going to give you the respect of privacy and let you introduce yourself to show that it was uncoerced and that you're willing to talk to the community about what it was like to be in our clinical study.
Thank you. I appreciate that. My name is Andrew Munsey. I go by Andy usually, and I'm happy to put that out there and advocate for studies like this. It's something that I was actively looking for a solution for my particular issues, and it's nice to be here to talk about it.
Sure. So one of the things that we do in medicine is we like to know a little bit about the background of our patients. And if you're willing to just share a little bit about your background, where you grew up and your profession, and how you ended up here in North Florida.
I grew up outside Washington, D.C. My parents were in politics and very much an industry town, and I did not follow them into politics, and got bitten by the writing bug and went out to Hollywood to become a television writer. Wrote for a couple of different shows, a comedy called Lifeline with Al Franken, that actually has had a lot of politics in it, and an HBO show called Arliss. But then fell into a marketing career out there, doing trailers for movies, and then ending up at NBC, working as a promo producer, doing the marketing for Friends, Frasier, Seinfeld, Will and Grace, shows like that. Had to move on to move up to, and went over to ABC and worked for them for a while. Went back to NBC for a stint and did The Office and a number of 30 Rock, number of shows like that. Ended up back at ABC, and where I finished up my career just a couple of years ago when I retired. And my medical history is that my background, my father had quadruple bypass late in his 60s, and sometime late in my 40s, my cholesterol was testing high, and started Lipitor and statin drugs that brought it down some. Diet and exercise had some effect, but wasn't doing enough.
Right. So let's drill into that a little bit. And I'll mention the fact that you're involved in a study here treating the cholesterol molecule called lipoprotein a. And it's actually a cholesterol-containing particle, but we use the term lipoprotein to describe these things. And lipoproteins are these molecules that circulate in our bloodstream that are combinations of fat and protein. And that has to be the case because cholesterol is a fat, and it's not soluble in our blood, which is mostly fluid, mostly water. So we have these lipoproteins, and we know that certain lipoproteins are more dangerous than others. There are favorable packages of lipoproteins, for example, HDL, or high-density lipoprotein. And then we have the less favorable packages, LDL, or low-density lipoprotein, but particularly lipoprotein a. And you mentioned a very common scenario for people with lipoprotein a, which is a family history. And lipoprotein a is a particle that is inherited at high concentrations in an autosomal dominant fashion, meaning that if one of your parents has this problem, there's a 50-50 chance they'll pass it along to the kids. So it sounds like you had this gene. And tell us a little bit, what was your lipoprotein a level? Did you know about it before you got involved in the trials?
I did. I didn't know about it when I first started on a statin drug. And I ended up having some chest pains playing tennis. And that's when I first started, or that's when they increased the they doubled the dose of the Lipitor. And then a few years after that, I had more chest pains, and I had my first angiogram. They found blockages. 3 stents were put in. I tried to be more concerted about change of diet, exercise, and that sort of thing. Had a second angioplasty and a third angioplasty for a total of 8 stents.
Wow. Okay.
In the end. And it was only after the third one that the lipoprotein A was tested and found to be 555.
Ooh, okay. Very high.
Over 5 times higher
very,
than
very high level,
it should be. Yeah. And sometime after that, in April of 2022, I began on Repatha. And
on top of the Lipitor.
Correct.
Okay.
Yes. And that has actually worked better than the drop by a third that it is usually done, getting me down to 311. Still 3 times higher than it should be, but happy for some reduction. And then I had 4th angiogram last December.
Wow.
And
keeping the interventional cardiologist busy.
Yes. Yeah.
Unfortunately for you.
And that time it was just an angiogram because they were not able to drill out anything or put in any stents. The blockages were too far down in the branches. And I always thought, because my father had the quadruple bypass, that was sort of my lot in life and would eventually be what happened. And of course, as you would know, I came to find out, well, bypass wouldn't help that issue.
And we call that distal vessel disease and cannot be treated with bypass, correct?
So, my concern continued to grow for how do I get on top of this, and what else can be done. And that's when I began pursuing the issue of lipoprotein A and found out about some studies at the Cleveland Clinic and the effectiveness of the new drugs. And I reached out to them and I said, I think I might be the perfect candidate for you.
You are.
And they let me know about the continuing studies going on, a list of them in the various states, and including Florida. And so I reached out to see if I was the right candidate.
Yeah, and you screened and you got in the study.
Yes.
And how long have you been in the study?
Since June, late June, I got my first shot.
Okay.
And have had no side effects.
Beautiful.
Everything's been great.
So I want to explore a few things. Fascinating history, a common history. We see this quite a bit in cardiology, and something that a lot of people in the public sector aren't really aware of. Most people know about cholesterol, of course, and I think the majority of people know about LDL, but very few people know about lipoprotein a. And one of the reasons they don't know about it is because we really haven't had a treatment specifically for it. You mentioned Repatha, which lowers it some. We actually did that work here in Jacksonville, and I was very involved in that work. And we showed that we can lower that lipoprotein 25 or 30% with something like Repatha, which is called the PCSK9 antibody. Evolocumab is the generic term for Repatha. But that's still not going to help that much, quite frankly, if somebody's starting out with an LPA level of 500 and it should be 25. Right. So we obviously have a lot of work to do, and we've had to develop other molecules. But before I get into that, I'm curious about a couple of things. What was your total cholesterol or your LDL cholesterol before you were on any drug? Do you remember what it was?
I think about 230.
Was your total or your LDL?
Total.
Total. Do you remember what your LDL was?
I don't.
Okay. And then after you got to Lipitor, it sounds like they started at a lower dose and titrated up. How high was the dose that you got to? Do you recall?
I think it went from 10 to 20 for the Lipitor.
What was the highest dose that you were ever on for that?
I think that's the highest.
It's 20.
Now I'm on rosuvastatin.
Rosuvastatin, yeah.
Rosuvastatin, thank you.
How much of that? 20 or 40 milligrams?
20, yeah.
Okay.
Yeah.
So interestingly, your doctors chose not to put you on the highest doses. Statins don't affect LP(a), lipoprotein(a), so that piece of the puzzle wouldn't be improved by those drugs. But you remember how much your LDL dropped or your total cholesterol dropped?
I think it went down to 160 in the end.
So from 230 total cholesterol to 160. Okay. Because the reason I'm bringing this up is one of the clues to people who haven't had their LPA tested is to see a less than expected drop in LDL when you put on a statin. So a drug like atorvastatin, or Lipitor, or rosuvastatin, or Crestor can lower your LDL cholesterol between 40 and 50%. And some people will only see maybe a 25% reduction. And the reason for that is that when you get a standard measurement of your LDL, or your bad cholesterol, the LPA portion is in that. Mm-hmm. And that LPA portion is not lowered by the statins. So you get less than expected drop in your LDL when you have a situation like yours. Mm-hmm. So that's an important learning feature for people that may be listening to this. If you have less than an expected drop in your cholesterol, or particularly your LDL, with a statin drug, there's a chance that this is because of lipoprotein A. And if you have a family history and that phenomenon of less than expected drop, please get your LPA checked. Right. Some people would argue that LPA should be checked for anybody with coronary disease, which is my standard for my patients. But certainly another clue would be this concept of less than expected drop. Mm-hmm. So let's change subjects just a little bit and talk about what the experience was to get involved in a clinical trial. Must have been scary.
Actually, no. I looked at it as an opportunity, knowing that it would be several years before these drugs would reach market, and the study I read said it had dropped the LPA down by 95%. Yeah. I thought that's what I want.
Sure.
And so, and from what I read, there weren't side effects to be concerned about. And so I had no fear going into it. I looked at it as an absolute opportunity.
Well, you'd be the exception rather than the rule.
Yeah.
So you hadn't done a clinical trial before that?
I had not.
Okay. Yeah, so I would think that most people that have not been involved in a clinical trial would be nervous. Mm-hmm. You did a lot of research, and obviously you looked at this very intelligently. But the truth is that when you're using products that are relatively new, that there may be some concerns. There may be even some fear.
Once you've exhausted all of the options you have of, changing your diet, increasing your exercise, reducing stress by retiring from a stressful job and moving to the Florida coast, and life is good, and you still have, another angiogram, your mind opens up.
Well, unfortunately, all those lifestyle issues will not touch your Lp(a).
Right.
It's interesting. We certainly advocate lifestyle changes, and diet and exercise can do wonderful things. They have modest effects on cholesterol in general. Mm-hmm. But LPA is one of these genetic concerns or diseases, if you want to look at it as a disease. But it's a risk factor that's because of your parents and your genes. And it's very, very difficult to change short of some of these new drugs and these really breakthroughs that we're working with now in research.
It's extraordinary. That's everyone has genes built in that you normally can't do anything about. The fact that medicine has advanced in this way to be able to stop the generation of LPA that your body's naturally doing is a wonderful opportunity, especially since it seems to have no side effects.
Yeah. Well, we'll talk about that. I would never say something has no side effects, just to be clear. But
my experience.
But a couple of things is, one is that one of my quips that I like to share with patients is that one of the most important things about your own personal health is to choose good parents.
Great.
And
well, I have that.
Right.
Maybe
well,
a
in
few
many
select,
cases, I'm sure
few
they're great
select
parents.
genes, maybe not.
Right. So, but with every choice, there may be a thing or two that you can make issue with. But nonetheless, in your case, you have this gene, and standard therapies have very little ability to affect this gene, and so you looked at clinical trials as a great option, and you're the perfect candidate. So, thank you for being part of the study, and hopefully it'll work out for you. Now, in fairness, we like to be very upfront. There's a chance you're not on an active drug when you're in a study. Did that concern you?
Sure. Mm-hmm. Sure. But I figured once I realized that I didn't have to change anything about my current medications, and that, either I got lucky and was on the drug, or, I was just doing everything I could otherwise.
Right.
So why not?
Right. So one of the things we talk about in our med evidence platform is the truth behind the data. And for things in medicine, things in life, quite frankly, but particularly in medicine, there's things that we know for sure. There's things we definitely don't know. And then there's a process to figure out the stuff we don't know. And that's what we do in clinical trials, is we figure out the stuff we don't know. So we do know that Lp(a) or lipoprotein(a) is a very potent risk factor for heart disease. And there are many families, like your family, where this is probably what's driving your cardiovascular complications. You know, you're a thin guy, you're a fit guy. I'm sure even in your previous life, before you had your stents, you were relatively conscientious about your health, is my guess. Mm-hmm. Nonetheless, you still had these complications, as did your parents. I didn't get into brothers and sisters, but they would have a 50-50 chance of having the gene as well, right, assuming it's just coming from one parent. And, you don't have to go into their whole story, but they would certainly be people I would want to screen, right, for this particular problem. So if they haven't been screened, I would encourage them to do so. But the point I'm making here is that we don't know if lowering lipoprotein(a) is going to make a difference. And that's why we do the studies. Mm-hmm. So another thing that we do know is, as you mentioned, we have products that can now lower Lp(a) by 90, 95, close to 100% in some cases. It's remarkable. And the product that has been the most successful is the product that you're participating in, the study of the product you're participating in, called a small interfering RNA. And this is now Nobel Prize winning technology that shows that our body has the natural ability to suppress certain gene expression. As you go back to your old high school or college biology days, you probably remember is that the genes are in the nucleus of the cell, and they send an RNA signal out to the cytoplasm of the cell, which allows our body to produce these proteins. And of course, in a lipoprotein, there's a protein. And we now have learned, again through scientific exploration, that we can block the transcription of that protein in the cytoplasm of a cell. And this is the concept of small interfering RNA, where we send a signal to the liver cells that make this bad protein and prevent that from occurring. And if you don't make the protein, you can't make the particle.
All right.
And so that hopefully that made sense to you.
It does.
And that's how these things work. And we know with this small interfering RNA technology, and there are products on the market, particularly one product that lowers PCSK9 using this mechanism that's now been on the market. We've done a lot of research with it. Very effective at lowering LDL cholesterol and appears safe. So this is a really exciting new area where we can intervene and have a huge impact. But we don't know yet if that lowering of the lipoprotein(a) will result in fewer heart attacks and strokes. Right. And you're helping us figure that out. So we appreciate that. And hopefully along the way, you glean some nuggets of information so that whether or not you're on the medication that we're testing, you'll get some benefit from what we're doing.
Right.
So talk to me a little bit about that. Tell people what it's like to come into a clinical trial center and be part of this. Is it like a doctor's office or different? Just a little bit of your experience.
It's been very easy. Because I had so many cardiovascular events and procedures, I'm fairly used to having to go for various appointments and things. And so it was all very easy to come in, take the survey, answer the questions. I had to go back and do some family medical history and check in with relatives about some of the specifics. But there was nothing to it.
And is it enjoyable? Do you feel when you leave the office after a visit, do you feel uplifted? Do you feel depressed, confused?
I'm very excited to be part of the study, and obviously, I'm very hopeful that it stops this pattern of needing some intervention because of a blockage. And beyond that, I'm aware of what about the rest of me? What about my carotid arteries and their blockage? And they've been scanned and they're in good shape now.
Good. Excellent.
But, I would hope that being part of this study would keep that being the case. So.
Yeah, it's interesting. When we do surveys of patients like you, obviously you're driven. The value proposition for you is to get a treatment that you can't get elsewhere. You stated that. Other people do it for different reasons. Some people just like the socialization of being part of this. Most people will say that when you go to a physician's office these days, the physicians are so stressed for time that they run you in and out as quickly as possible. Whereas in a clinical trial setting, it's much more relaxed. much more comprehensive. It's actually more social.
I definitely agree with that.
Yeah. And, for some people, they're driven by the fact that they get compensation for what they do in the studies. That's a driving factor for some people, not for everybody. In a case like yours, it's really access to the product and trying to change your disease course.
Yeah, I didn't realize that was part of this, but it's a nice little bonus.
Yeah. And then the other item that I think is relevant in your case, and correct me if I'm wrong, but there's a legacy issue. I don't know if you have children or not.
But one daughter.
Yeah. Has she been tested for LPA?
Not yet.
Okay.
No. But she knows that she needs to on their next checkup.
Well, let's test her. We'll do it for free here.
Oh, thank you. Okay, that'd be great.
Yeah, so it's actually a relatively simple test, but it probably would not be recommended by her primary physician because, again, it's not part of national guidelines yet for somebody that doesn't have coronary disease.
Right.
But given the family history, why not? And again, siblings of yours should also be tested if they have not already.
Yeah, and even after it took the third angioplasty for mine to be tested a few years ago. So
well, hopefully that's going to change. Where part of this is to educate physicians as well as patients about this particular problem. And we're in that zone where we don't have all the answers yet. So we do think that interventions of lipoprotein a will be important. We know that lowering LDL in patients like you is very, very important. But you're going to be part of this process where doctors and patients around the world are going to help us figure this out. So I thank you for your participation. It's really, really important. And the other thing, I was very pleased to hear that Cleveland Clinic kind of guided you along the way. We work with Cleveland Clinic on a number of projects. Steve Nissen is head of cardiology at Cleveland Clinic, and he and I have published together on multiple occasions. Terrific guy, just evidence-based guy, so we have great conversations. And the fact that we all work together as a fraternity, if you will, of people that run clinical trials is a neat part of what we do. So we share data with each other, and interestingly, people in Europe and around the world will learn from your experience, and the flip side is I'll learn from the experience of patients that are in Asia and Europe that are part of these trials as well. So again, we thank all of you for your participation.
Happy to do it.
So any final words that you want to share with the audience that may be considering doing a clinical trial?
Just I agree with everything you've said. It's easy. It's nice to have the opportunity to have a discussion on these issues, and especially such a specific issue that my cardiologist and primary physician were aware of and knew that it needed to be tackled, but weren't in a position to take advantage of these new advances. So I just think the clinical trial is a wonderful opportunity to do that, and hopefully I'm getting the drug, and if not, then hopefully it will come to market at some point. Will help me down the line.
And in many cases, the manufacturer will make that drug available if it's proven to be successful. Again, we can't guarantee that, but I am lobbying for it as we speak.
Excellent.
So one of the things that I do for all my patients is to make sure the manufacturers know how important that is. So you mentioned Repatha, and that was an example where we successfully lobbied Amgen to make Repatha available for the people who participate in clinical trials, whether or not they were assigned to the drug during the course of the study. So, Andy, thank you for being part of the study. Thank you for being part of MedEvidence, and thank you for being part of the process of making healthcare better.
Thank you for your work you're doing.
Thanks for joining the MedEvidence podcast. To learn more, head over to medevidence.com or subscribe to our podcast on your favorite podcast platform.